Assalamualaikum and hi everyone. We are from group 6A and we would like to present about our case study regarding retropharyngeal abscess. There are 6 outlines of our presentations. The first one is the introductions, the second one is our case presentation, third is disease process, fourth is management and outcomes, fifth is the nursing care plan, and the last one is the references.
For introduction, this is a case of Mr. F, who was diagnosed with retropharyngeal abscess with underlying condition of hypertension. Retropharyngeal abscess is a deep neck infection behind the pharynx, usually caused by bacterial infection, trauma, or spread from nervous structures such as tonsil, sinus, or teeth. It can lead to symptoms such as severe sore throat, fever, dysphagia, and can impair airway patency. Why we choose this patient? This patient case is interesting because the symptom of retropharyngeal abscess can vary widely, such as mild sore throat and dysphagia, to severe airway obstruction and neck stiffness. This variability necessitates proper intervention, clear goals, and careful evaluation to improve outcome and prevent serious complication. Finding the correct diagnosis for retropharyngeal abscess can be difficult because the symptoms are similar to infection or benign neck mass. In this case, advanced imaging and proper treatment are very important to confirm the disease and guide care.
Start with patient's biographical data. Our patient's name is Mr. F. He is a 40 years old Muslim and Malay man. He is currently married and able to speak 3 languages, which are Malay, Melanau, and English. He was admitted to the hospital on 30th July 2025 via ETD, and he also came in as walk-in case. During our attachment, he is warded in the ENT and neuro ward due to the left neck swelling, which was the main reason for his current hospitalization. Patient's chief complaint is about his swelling on the left side of the neck. So he reported that he used to experience neck swelling previously, which has been subsided. However, about 1 month ago, he again noticed a swelling on the same side. Initially, it was small and did not resolve. However, in the last 2 weeks, the swelling has shown a rapid increase in size, becoming larger and more noticeable. So because of the persistent and progressive swelling, the patient decided to go to the hospital. There are 2 presenting systems for this patient. So the first one is the swelling at the left region of the neck. Like I said in the previous slide, the patient complained the swelling was small and painless, but in the past 2 weeks, the swelling has shown a rapid enlargement, causing an extremely noticeable. So patient also described that the swelling is firm and localized without any discharge or fluctuations present. For our observation, we see that the swelling is reddish and warm to touch, and it is true that there is no ulceration or any discharge present. Also, patient did complain about pains associated with the swelling. At first, he said that the pain began as mild discomfort but become more persistent and bothersome as the swelling increased. So he did describe that the pain is like dull and aching pain localized to the left side of the neck. And he did say that the pain become more worsened if there is a neck movement such as turning the head, and it can only be partially relieved by rest. So the patient also did say that there is no radiations of the pain to any parts of the body such as ear, throat, or jaw. So for our patient's past health history, he is underlying with hypertension, and he used to admitted in the same ward on February 2025 due to the similar experience, which is the left neck swelling, but he underwent incision and drainage procedure IND on March 2025. He did say to us that the swelling has been reduced but recurred months later, leading to the current presentation. So during our interview, he complains that there is a painful and difficult to swallow food, but denies any difficulty in breathing, fever, sore throat, or any changes in voice. For his family history, he told us that his mom has colon cancer and passed away in 2023. Socially, he lives with his wife in his in-laws' house. He also not smoking and drinking. And lastly, he reported that he marked unintentional weight loss from 75 kilograms to 62 kilograms within 2 weeks.
Assessment on body system. The first one is cardiovascular. Patient present with hypertension and managed with amlodipine. Second is neurovascular. Normal suspension at left neck region and patient capillary fill below 2 seconds and edema present at left neck region. Lastly, integumentary system. Patient skin is red and warm and bruises are not observed. Assessment on component area. The first one is inspection at the neck, swelling at left side of the neck, and possible asymmetry of the neck. Second is range of motion of the neck, painful and restricted movement, especially extension. Lastly, palpation at left neck, swelling at the left side of the neck. Result of clinical examination of blood gas. pH is slightly alkaline, Oxygen is below the normal range, which indicate hypoxemia. Carbon dioxide below the normal range, which indicate hypocapnia. HCO3 also below the normal range, which indicate metabolic acidosis. And lastly is base excess below the normal range, which indicate metabolic acidosis. After that, we go to the ion. First is sodium. Sodium is normal, which indicate proper fluid balance. And potassium is below the normal range, which indicate hypokalemia that can lead to muscle weakness and fatigue. Lastly, calcium. Calcium also below the normal range, which indicate hypocalcemia that can lead to muscle weakness and nerve function. Other than that, white blood cell is increased, which indicate infection or inflammation. Red blood cell also increased. Lymphocyte is low, and neutrophils indicates bacterial infection.
Retropharyngeal abscess is an infection that occurs in the retropharyngeal space, which is a space between the buccopharyngeal fascia and the alar fascia. Normally, this is just a potential space, meaning in healthy people it remains closed. The buccopharyngeal fascia acts as the posterior border of the pretracheal fascia, while the alar fascia is the anterior subdivision of the pivotral fascia. These two fascias fuse around the level of the T1 vertebra, forming the retropharyngeal space. So, essentially, this area is not usually open, but under certain conditions like infection, it can become a site for abscess formation. How does a retropharyngeal abscess develop? It often starts with an upper respiratory tract infection, URTI, caused by pathogens such as Group A Streptococcus, Staphylococcus aureus, or Haemophilus. The infection can spread and cause inflammation of the lymph nodes located in the retropharyngeal space. And as the inflammation worsens, pus begins to form inside these lymph nodes, leading to what we call as suppurative adenitis. The accumulation of pus then forms an abscess, which gradually enlarges and can obstruct the upper airway, which making the breathing difficulty. It's also worth noting that about 1/4 of cases are due to trauma of the posterior pharynx, where bacteria are directly introduced into the space, eventually forming cellulitis, plaquement, and then an abscess. So, what do we see in patients with a retropharyngeal abscess? The most common symptoms is painful or difficulty in swallowing, also known as dysphagia. Patients may also have neck stiffness, torticollis or a tilted head posture, tender cervical lymph nodes, and neck pain. Other symptoms include trismus or the inability to fully open the mouth, swelling of the neck, chest pain, and loss of appetite, and also general malaise. As the condition progresses, more serious signs appear, such as noisy breathing or stridor and difficulty breathing, also known as dyspnea. These symptoms are red flags that the airway might be compromised and need urgent attention.
So, the first management that we can say is the procedure management, which the patient undergone intraoral incision and drainage. So, one of the preoperative procedure is, the first one is assess pain score and ability to swallow, then obtain imaging results and diagnostic tests, explain procedure to patient and obtain consent, provide comfort measures pre-surgery, and last but not least, we need to advise patient to maintain 6 to 8 hours of fastings before anesthesia. Then, post-operative procedure, we need to monitor vital signs, especially oxygen saturation and pain score, assess for bleeding and signs of infection on the incision site. Then we need to administer prescribed analgesic and antibiotics, encourage semi-bolus position to promote comfort, start with clear fluids, progress to soft diet as tolerated, and last but not least, educate patient and family to inform the healthcare workers if the symptoms persist. The next management is pain management. Firstly, we need to assess the pain on the surgical side by using a standardized pain scale to the patient. Next, we need to administer analgesics as prescribed by ensuring the right type and dose for specific pain. Then, we need to monitor the side effects of analgesics to the patients by evaluating the effectiveness of the pain control measures. Other than that, we need to encourage the patient involvement in non-pharmacotherapeutic intervention, such as relaxation techniques and listening to music. Last but not least, we need to educate patient for pain management by explaining the importance so that the patient can give cooperation. These are the pharmacological management. As you can see, there are lots of medications prescribed that are served to the patient, from antibiotics to opioids, from NSAIDs to corticosteroids. The patient must take according to the dose, the frequency, and the route. As a nurse, we need to administer the prescribed medications by the doctor to the patient and then monitor for the effectiveness of the medication to the patients and also check for the adverse effects by the patients. If the medication is out of stock, we need to inform the pharmacist immediately. For health education and discharge planning, we need to assess patient understandings and knowledge by teaching and guide them in managing quality care, asking them to explain their condition and post-operative care in their own words, and clarify any misunderstanding and misconception about patient's health condition. Then, follow-up care. The patient needs to follow up appointments with physicians and dietitians for monitoring recovery. Inform them if the swelling recurs or pain worsens. After that, ensure understanding and self-care ability. We need to ask the patient to repeat back and restate the instructions. Last but not least, provide written discharge materials. We need to summarize the overall management and plan of care to the patients. For outcomes, for pre-operative procedures, the patient is able to understand the purpose of the procedure and give informed consent. The patient reports improved comfort and reduced anxiety, and patient maintains fasting status before procedure. So, post-operative procedures, the vital signs remain stable within the normal range. There is no evidence of excessive bleedings or infection at the site. Pain is controlled as well as the patient's comfort. Patient is tolerating clear fluids, thus can proceed to soft diet. Last but not least, patient and family understands the symptoms occur and inform the healthcare workers promptly. For pain management, the patient reports of reduced pain from pain score 6 to 2 within 24 hours monitoring. The prescribed analgesics are effective with no harmful side effects. The patient feels better with his non-pharmacotherapeutic intervention, and it is able to understand and give cooperation easily about the management. For pharmacological management, we can say that the patient shows compliance with the prescribed medications and understands the importance of strict adhering medications. Other than that, the patient also shows no any side effects towards the prescribed medications. For health education and discharge planning, we can say that the patient understands his condition, treatment, and care needs. Then, the patient will do follow-ups and knows when to seek help when the symptoms persist. The patient is able to explain back instructions clearly and understands written discharge materials and knows how to contact with the healthcare workers. In the conclusion of the treatment, what we can say is that the patient has demonstrated ongoing active participation and compliance with the established care plan. And then the treatment were effective in resolving the primary issue. And then the patient was advised to attend follow-up appointments to monitor recovery, assess his condition, and determine if any additional interventions or management are required.
First one is acute pain related to inflammatory swelling of retropharyngeal tissues as evidenced by patient's verbal reports of dull, etching neck pain aggravated by movement and observed discomfort. Subjectively, the patient said it hurts when I turn my neck and the pain has been getting worse. Objectively, there was swelling, redness, warmth, and restricted movement. The short-term goal was for the patient to report pain reduction within 24 hours, and the long-term goal was for him to be able to move his neck with minimal pain before discharge. Interventions included assessing pain every 4 hours to evaluate response, encouraging the patient to maintain a comfortable position such as semi-fowlers to reduce strain, administering prescribed analgesics like tramadol to relieve pain, teaching relaxation techniques to complement medication, and educating the patient and family on early pain reporting to prevent worsening. The evaluation showed that pain decreased within a day and the patient was able to rest and move with less discomfort by discharge. For the second nursing diagnosis, imbalanced nutrition, less than body requirements related to inflammation and edema of pharyngeal tissues secondary to retropharyngeal abscess as evidenced by dysphagia, unintentional weight loss, and dependence on nasogastric tube feeding. The patient expressed it's hard to swallow food, it feels stuck. Objectively, he had difficulty swallowing, was on an NG tube, and had lost 13 kilograms in 2 weeks. The short-term goal was for him to tolerate NG feeding safely, and the long-term goal was to resume a soft oral diet and maintain weight. Interventions included assessing swallowing ability to prevent aspiration, maintaining upright position during and after feeding to reduce aspiration risk, providing a high-calorie, high-protein, soft diet to promote healing, referring to a dietitian for individualized planning, and educating the patient and family on safe swallowing practices. Evaluation showed he tolerated NG feeding without aspiration and later resumed oral intake with stable weight. The last nursing diagnosis is risk for infection spread, as evidenced by the presence of localized retropharyngeal abscess with rapid enlargement, redness, warmth, and a history of incision and drainage for the same condition. The patient said the swelling on my neck keeps getting bigger these past 2 weeks. On assessment, there was redness, warmth, rapid enlargement, fever, and elevated white cell count. The short-term goal was to remain afebrile with stable vital signs within 72 hours, and the long-term goal was to remain free from systemic infection throughout admission. Interventions included monitoring vital signs every 2 to 4 hours to detect infection early, assessing for systemic signs such as chills or confusion, administering prescribed antibiotics promptly to control bacterial growth, promoting hydration and balanced nutrition to strengthen immunity, and educating the patient and family on signs of worsening infection. Evaluation showed the patient remained stable, afebrile, and free from systemic infection until discharge.